my become colleagues, Gayla True and Leslie Alexander, emailed me about some research I was doing and said, you know what, I think it has a lot in common with what you're doing. We've just done some qualitative work with community health workers, looking at some of the well, they didn't use moral stress. Look, they were interested in the unethical behaviors of community workers that were sent out into the street. And so they said, let's get together and maybe we'll write a grant together, which we ended up doing, and it got funded. What I want to say, and I'm not going to go into detail about this study because I'm really only interested in the demographics with you and the recruitment issues, but totally changed. We found it totally changed from looking at the unethical behaviors that community workers do to some other things, which was really derived from our focus groups, which then turned into a large-scale survey study. So why study frontline researchers? Well, what is a frontline researcher? And I think it was interesting because PEG was really kind of training them, but they were delivering things. But we all have frontline researchers that we work with, and those are the individuals who are engaged in the direct contact with participants. And I think what a lot of you find and what makes PEG so impressive is that many of us, once we continue to, kind of advance, don't have we're never face-to-face anymore with the people that we're actually testing, and that may have some implications, which I think we found out in this study. So we were interested in, frontline research workers in community-based drug use research because they are interacting with the most vulnerable of individuals, right, who have economic, health, other social vulnerabilities. And there was a paucity of research on the emotional toll such interactions may have. Now, once again, I'm placing this within a framework of what we learned because before that, we weren't even thinking about the emotional toll. We were thinking about what they were doing that might be invalidating research. So by the time we got to the survey study, which this is about, the goal was to identify and develop empirical measures to assess the risk and protective factors associated with work-related attitudes and activities among frontline research workers. Now this is important because you can see that this is an aim, right? And it's not, we conducted a survey to do this, but it's the aim of what we want to do. Well, we don't have to do that, but basically this is a lay of the land because we're really only doing descriptions. But it ends up that we are able to have some prescriptive value, which I also add. So anyhow, the preliminary focus groups were unbelievable. We ran 6 of them in 3 different cities. And what we found, which changed the entire study, was how committed they were, number one, to their work, but also how frustrated they were that they would go in and they felt that their PIs knew nothing about the communities that they were working in, that the PIs would tell them they'd have, let's say they'd have criteria for heroin or, heroin use or injectables, and you'd have to use them within the last week. And the community workers would know that for whatever reason that drug wasn't available that week, but this was a person that used all the time. And so they felt, for example, that the criteria really was not real world in terms of who was an injection drug user or the type of drugs that they did. They were very frustrated that sometimes they felt they were being pressured for the numbers, even though people didn't really qualify for the kind of study. They felt that they felt very frustrated that they couldn't provide services, that maybe they were taking advantage of people who really needed a lot, and yet they were just doing descriptive studies on them. And so we found that some of them were actually counseling because they had been trained as counselors. So they were doing some counseling with the individuals, which you can imagine to threaten some of the validity of the studies that were going on. We found that some of them, especially those who lived in the community, felt that there was a lot of burden on them because people would ask them all the time for favors, thought that they were their connection to health care, would be asking their advice. And while somewhat empowering, it actually became a burden, like Peg was describing. Don't knock on my door at 12 and 1 o'clock for condoms. They were being asked for money. They would give money to people. They felt that one way to encourage them to be in the studies was to do. Anyhow, we found out all this. We had no idea. And it wasn't what. So basically, by the time we got to our developing our survey measures, it had nothing to do with what we thought the study was going to be about. So I'm listening to this, and we're doing the qualitative analysis, and I so is there some framework that we can, understand what's going on with them? And there was nothing in our literature that said anything. And so I finally found in the nursing literature that what's been going on for years, it was this whole concept of moral distress. And moral distress in nursing is when they want to do something right, but because they have to listen to the doctor, they're limited. So it's really this frustration with institutional and role barriers to doing what somebody thinks is morally right. So we rephrase this in terms of the research role in that moral stress is feelings of anger, frustration, powerlessness, and job burnout when morally appropriate actions cannot be implemented due to constraints imposed by role obligations and lack of organizational support. So I took from the nursing literature, and this was really helpful. So we created measures based upon the issues that we were told about in the focus group. So we have measures of moral stress, and we took their language and made them items. That's basically what we did, as well as drawing upon some of the other literature. We then created a scale of moral practice dilemmas. Remember, I was telling you some of them felt pressured by the numbers, so they'd put people in who might not qualify. Or they would give money to people, or they would do counseling when they weren't supposed to be doing those kinds of things. So we made a scale out of those kinds of things. But rather than think about them in the way that my colleagues had originally thought about them in terms of unethical behaviors, these were really moral practice dilemmas because they felt torn between the role of helper or the role of and the role that they were given, or they just which caused them to do some of these things. We then also had a scale of research commitment, research mistrust. We wanted to see the extent to which they shared with participants that we had studied before, whether or not they also were distrustful of research, and then how supportive their organization was. And we called that organizational support, but then also whether or not they were actually trained about ethics. Did the organization have a research ethics climate? So our hypotheses were frontline workers who evidence strong research commitment and who report high levels of organizational support will experience low levels of moral stress. So you can see this is a quantitative study, right? And then FRWs who are distrustful of the research enterprise and who frequently grapple with moral practice dilemmas will also have higher levels of moral stress. We went through the NIH Research Portfolio online reporting tool and the Clinical Trials Network, and we identified everybody who had a grant in the last 3 years. And then, of course, we needed what should be our inclusion-exclusion criteria. Like we're asking them to identify people.
Well, you're saying they need to have had face-to-face contact
Exactly.
with participants.
Right.
That's gotta be part of it.
Right, exactly. Direct contact. We don't want to be too limiting. And one other thing that we decided to do, we said they had to do it in the last 12 months. The reason being, we're talking about stress. So, it can't be that it's been 3-4 years ago, because then the correlation between the measures wouldn't work. Okay, good. So, were they involved in face-to-face recruitment, the screening, the enrollment, intake, informed consent, face-to-face? So what I'm telling you is we put all this in. That's why I'm sharing this with you, because two reasons. Nobody had ever described who these people were, number one, and what they do. And number two, maybe what they did had something to do with whether or not they had moral stress. Interviews. So these were all the things that we asked them about, and asked if they engaged in these kinds of activities to find out. Now, I'll just tell you what was interesting is none of this was correlated. The reason being they all had multiple roles, which is also something that contributed to stress. They were doing so much that we couldn't correlate in the end, even though I'm glad we asked these questions, because as I was saying yesterday, a reviewer would ask me, well, what exactly were they doing? And was that related? And we needed to be able to say, it's not, but this is why. So, age, gender, ethnicity, education, personal history of drug use. Community residents, do they live in the community? Because remember, our focus groups were talking about that pressure, and like Peg said, and whether they shared ethnicity, cultural language with the participants. So what we ended up doing is we actually asked them how frequently, because the climate was kind of like that, but the demographics was so number of years working, right? Whether their experience increased stress or decreased stress, who would know? The number of projects they've worked on, whether or not they were full or part-time employees, their income, whether they felt financially secure. We had, I think it's 3 options. Do you feel I can't remember the exact language, but it had to do with just enough, more than you need, less than you need. So, because that can obviously contribute, because part of our definition of moral stress includes burnout. So, and then whether they were given health insurance, how often they met with their supervisor, the vulnerabilities of their participants. Remember, a reviewer might say, wait a minute, is it, maybe it has to do with who they're working with. So we asked that, and the type of study, whether it was descriptive, preventive, or an RCT, because I think sometimes people may feel more, from our focus group, it seemed like if you're not providing services, people felt more stress about that. Okay, the major findings, which I'm really not going into, approximately 50% of the FRWs experience some level of moral distress. We defined that, by the way, in terms of, I think it was a 4-point Likert type scale. So it was looking at the percentages that reported very much, or yes and very much, or whatever the language was. We found, as we had predicted, that role commitment, organizational support, organizational procedures specifically addressed to research ethics, and age and frequency of meetings with supervisors were correlated with whether or not they had moral distress. And the risk factors were perceptions of research as exploitative. That was our research mistrust questionnaire, and the extent to which they confronted these moral practice dilemmas. So the major findings of individual and work-related variables, very few, but I'm glad we asked them. So it did provide the first description of who these people actually were, including the fact that they navigate these multiple roles. There was the only age and number of times they met with their supervisor was the only demographics that worked in terms of our particular study. So one of the conclusions we had was that stress is related to the context of doing this work and not necessarily to the individual factors, individual characteristics. So I think that was important because we were able to weed that out. I just wanted to point out that, remember we talked about implications for investigators. Whenever I gave this talk, and I've given this talk a lot, the PIs are, oh my goodness, I didn't know this, most of them are saying, and so lack of attention, so that they really need to pay more attention to the emotional toll of that frontline research workers are facing, and the way I get to the PIs is that it's threatening the validity of their research if they don't attend to this. And in addition, there was a lot of complaints about the fact that the PI doesn't really know what's going on in the community. So another recommendation is for them to obtain firsthand knowledge of the research community and go out with their individuals, and to set aside regular team sessions for debriefing and feedback. And that's also just a start on demographic variables and